case. The task was actually to discuss about a gastrointestinal cancer patient related to palliative care. But I have taken a different patient with gastrointestinal symptoms. All right. We'll directly go to the case. This lady, 61-year-old lady, Mrs. A. Actually, this patient came to ETU, Emergency Treatment Unit, on 3rd of October. I mean, few days back, with a history of few fainting attacks, fever, and ill health. So it was a busy working day for me. The MOETU informed me over the phone about this lady, that she has been diagnosed with cervical cancer in 2021, and she has undergone surgery, external beam radiotherapy, chemotherapy, and later vaginal wall brachytherapy. However, the family and the patient, they are not happy with their primary consultant and go on to India for a second opinion. So this was the information given to me over the phone by the MOETU. So, I mean, how relevant these information are now? Looking at this history, I know this is a cancer patient and who had diagnosed very recently and undergone major curative treatments, and now coming with a problem. So during this conversation, what are the important, I mean, to even before going to the patient, what is the most important information you gathered from the MO, Emergency Treatment Unit? Can anyone tell? Okay, so I will quickly go. For me, actually, I can understand there is a conflict. There is already a conflict between the healthcare professionals and the patient and the family. So I have to be very careful now, right? I have to be very careful, because if my communication with this patient and the family is not going to happen in the precise, I mean, in a very good way, there is a very high chance that I will not be able to help this patient, right? So with that information, so there is a conflict, right? So in palliative care, one important thing is not to have conflict with patient and the families, with the healthcare professionals, because if you have any conflict, patient and the family, also us, are not going to get any benefit. I mean, patient and the family will not get any benefit from the treatment, because that is very important to have a very good doctor-patient relationship, clinical professional relationship between the patient and the healthcare professionals. So what I did was, I quickly went to the ETU and see there were about few people around the patient. One was the daughter and the other one, of course, the husband. So I asked the daughter, I didn't straight go to the patient. I asked the daughter and I introduced myself and I told them, is it possible for me to have few words with you, right? Because I don't know whether this patient knows about the condition, whether this patient knows her prognosis. I don't know anything. Then she said yes. Then I asked her, okay, would you mind taking a few minutes? Would you mind be seated here? And I need some information regarding your mom. Is it possible? She said yes. Then actually, she was a little bit happy that I was giving some time and some attention to them, right? So those words are very important. Giving time and attention to the patient and the family, right? Those are very important. So she told me that she got a very early recurrence, and we know that she had a cervical cancer, and she got very early recurrence, and they went to India, and the investigations reveal that her disease has spread to the abdomen and infiltrating the bowel loops and bones. They were very unhappy that staging investigations were not done initially, and there were no follow-up investigations. So they think that since those investigations have been not done, so they couldn't identify this metastatic disease early. I mean, this is less than 1 year period from the initial diagnosis. So, but however, they know that her disease is not curable now. So whatever the treatment they are doing is to control her cancer, and she has taken palliative chemotherapy in India, and second cycle was completed 2 days back. So this is after maybe less than 7 days after the second chemo. So they have noticed a small abscess forming in her abdominal wall. So the clinicians there, they have started oral ciprofloxacin, and after coming back to Sri Lanka, they have taken a swab from the abdominal wall wound and sent for culture, and already they are having the report with them. Then they showed me the report, so I went through it. Then I saw coliform organisms are positive, which is resistant to cipro and sensitive to cefuroxime. So I told them, because the history is fainting attacks, fever, and ill health. So there is an infection clinically. So her heart rate was actually high, but fortunately blood pressure is normal. So she's not in very bad shape, but there are signs of infection. So actually her diagnosis now, according to the ICD code, it's cervical cancer initially. This poorly differentiated part I added because I even discussed with the relatives. They didn't show me the report, histology, but I think it should be a poorly differentiated carcinoma because it has metastasized even with a FIGO stage 1. So FIGO 1 means very early stage cancer, and undergone surgery. I don't know even up to now why even FIGO stage 1, maybe C, why they have given radiotherapy with chemo. So that should be either margins positive or something like that. So anyway, now the diagnosis staging has changed to FIGO stage 4 because bone metastases are there, and it has spread to bowel loops. And they have discussed with the surgeon locally as well as in India. The surgeon said surgery is not possible at this stage. So this is so then I told the relatives, shall we go to the patient and talk to her? So again, I introduced myself to the patient because earlier I have introduced myself to the relatives. Then actually she was a very pleasant lady. She was talking very nicely. And I asked her how she is. She said, I am having difficult few days now. I had fever and several fainting attacks. So here I am. What can you do to me? Then I said, can I examine your wound? Then she said, yes, why not? We have done the dressings today morning, but it's okay. You can check. Then I examine it, and I have found, I noticed some fecal matter is coming out of the wound. So what do you think? Fecal matter coming out of the abdominal wall. What it could be? That's a fistula, right? So it's compatible, no? Heavy disease infiltrating abdominal content, the bowel loops, and the surgeons has mentioned that surgery is not possible, and fecal matter is coming out of the abdominal wall. So it should be an enterocutaneous fistula. So actually this picture is not from that patient, but from I have taken it for discussion. Actually, the opening was not this big, very small opening, and I saw some greenish color stool material, fecal matter. The moment I saw this, I know I understand the situation, and I told the daughter and the father, now there is definite infection is there. But the problem is there is some additional information is there for me to tell you. Is it okay? So they said, okay, tell us. So before telling the patient, since our culture is different no, to the Western culture, so I explained this to the husband and the daughter. So I told this is clinically this is a enterocutaneous fistula, and you must have taken a swab from the fecal matter actually, but there is definite infection, no doubt. So we did some small, few blood investigations, CRP, full blood count, to know what's going on. And since the ABST is different, telling Cipro is resistant, I didn't want to stop antibiotics straight away. I said, since there's infection, we'll change to cefuroxime. So this is something like a trial of antibiotic, whether patient is going to get any benefit from the antibiotics. So we need to give and see, because infection sometimes reversible, but in her case, it is not going to be a permanent cure. It will come back again and again with different sensitivity forms. But for the time being, we started antibiotics, and I asked the relatives, is it okay for you to admit this patient for a few days for me to observe and see what else I can do for her, rather than telling the patient directly admit. So that is our usual practice. No, if we want to admit, we tell the patient you need to admit. But what I asked was, is it okay for her to admit for a few days? So these words are very important, even though you might not see any difference. Admit the patient and whether I can admit her for a few days. That has a big there's a big difference in the meaning. So what I did, we cover the enterocutaneous fistula orifice with a urostomy bag. This is again not the same patient. The picture is different. So this patient was put in dressings every day, but now she feels little comfortable because the content is now covered with a bag and it's filling to the bag. But the next day we observe the orifice is getting bigger and bigger, and later she developed watery high output fistula from the opening, from the fistula opening. So a lot of liquid content is coming out now. Output is very high. So this is going to give a lot of problems now. So if there is a fistula or any even ileostomy bag, if there is very high output, what will you do? What will you give for that? We usually give codeine syrup. So I gave codeine syrup, and with one dose, it has a good response, right? So we identified the problem early and we act quickly, and we are not going to stop it. We will further assess. But I didn't want to continue codeine because she has bowel opening from the normal route also. So I don't want her to get constipated. So with one dose, I stopped the codeine and I put on demand or PRN doses for her. So if she get high output again, she can take another dose. Depending on the situation, we can give. So again, we settled that problem also. Now, we noticed that she developed fatigue. She was getting fatigued, very tired. So we checked her hemoglobin 7.7 and her electrolytes, because she had a high output from the stoma, the fistula orifice. The sodium, potassium, and calcium are very low. So what will you do? Now this is an incurable patient, palliative. What will you suggest? Any comment? Please talk.
Hartmann's like fluids we can.
Sorry?
Hartmann's like fluids.
I can't hear you.
Hartmann solution, heavy fluids.
Yeah. So that's a good idea. But we'll try to, at the moment she can take oral. So what I gave was, we gave table salt, and usually how we replace table salt is, we take very cheap capsules which are not very expensive, any medicine. I mean, simple medicine like maybe omeprazole or that sort of thing. We remove the content inside, fill with salt, and ask the patient to swallow it with water. Right. Other thing is, you can give it mixed with fruit juices. Right. And potassium, of course, I had to start KCl infusion because potassium level was that low. And calcium, we gave calcium carbonate. And what about hemoglobin? Hemoglobin is 7.7. Do you like to do anything? This is a palliative patient, non-curable.
Stage, no.
Sorry?
In this stage, better not to.
Okay. So go back to the definition, palliative care. What we do, if there are reversible causes for suffering, are you going to reverse it or not? You can reverse, and you can try and see. I mean, sometimes that is why now, if there is an infection, you give antibiotics and see whether patient get benefit. Maybe you can assess after 3 days whether there is an improvement. If there is no improvement, if patient is terminal, if patient is end of life care, yes, you can stop the antibiotics. You can't, I mean, even end of life care, patients can live for a few weeks. Definition is up to 1 year. So, I mean, if the antibiotics can reverse the infection, you give antibiotics. If the blood transfusion can reverse the fatigue, so we give blood transfusion. So we give we gave actually 1 pint of blood, and after that, I mean, with the electrolyte replacement, she became better. So our trial is positive, and trial actually give good results. So we tend to continue the electrolyte replacement, but with 1 pint of blood we stopped, because after that her hemoglobin became reasonably, I mean, above 8 is okay. So 7.7 with 1 pint, it picked up to level of 9. So that is more than enough for us, and she is clinically okay now, right? So we managed, and we continued sodium, potassium, and calcium. Right. So then she developed another problem. Now, these patients will not come with 1 or 2 problems. Continuously, you will get many problems. So she started to pass blood from the fistula and per rectum. So what will you do? Now, surgeons has already told they cannot even touch the abdomen, because the abdominal content is mattered with the due to the malignant spread, and already there are fistula formation. So now you can see she is bleeding. This may be due to tumor infiltration within the, I mean, there may be from the blood vessels. And each and everything, even the electrolyte replacement, giving blood, before all these procedures, I had to discuss with the family members and the patient. And I explained hemoglobin is low, that can contribute to the fatigue. So we will give 1 pint of blood and see whether you are getting improved. If you are improving, again, if you get fatigue, we'll check the hemoglobin, and if it is low, we can give another blood. But if the frequency of transfusion is very quick, I mean, high, frequency is very high, then we have to decide whether we continue or not. And the electrolytes, you had high output from the fistula, so there may be a lot of electrolytes losing from your body. So we'll try and replace the electrolytes, and if it is giving any benefit, yes, we continue, and we saw the benefit and we are continuing. Likewise, now we see another problem. Blood is coming out of the fistula orifice as well as the rectum. So we need to explain this. Otherwise, the relative doesn't know why this blood coming. So we have to tell the tumor may be infiltrating surrounding structures inside the, inside bowel. So that that leads to the bleeding. So what will you do? I mean, what you need to do is to stop the bleeding. How can you stop bleeding? So I mean, if this is due to microvascular bleeding, we can try tranexamic acid. So I have explained this to the patient as well as the relatives, and I told them, okay, we will try tranexamic acid infusion, and if it is working, we will continue oral. So we started it and it settled. I mean, luckily it has settled, and we have explained everything to the family and patient before doing any new thing, because as doctors, we don't have the authority to do anything without informing, only during an emergency. If we don't have time, yes, we can do, but here we have enough time to explain. And then relatives are happy, patient is happy, because we are giving a lot of attention to the family and the patient, right? And it may be a very new experience for them, because they were unhappy at the initial stage, right? They were unhappy, but now they are becoming, I mean, they are building the trust on local doctors, right? Okay, so we started tranexamic acid, and it stopped the bleeding temporarily. It might bleed again, so I have to inform them. So these sort of situations, I mean, we need to keep some dark color linen standby, right? Either in hospitals we have dark green, dark blue. So if patient started to bleed heavily, then we should not put any white color linen around her. We have to put dark green or dark blue, so the patient or the family members will not see the red color. Otherwise that will frighten them, right? So those things has to be ready. So after getting all this information, her daughter, now I have explained, now I know that she is undergoing chemotherapy in India, right? If I tell her no point getting chemotherapy, you see now patient is anyway going to die, what is the purpose of having chemotherapy? Then again that trust will not continue. So I asked them, what do you think? Now your mother, your wife has undergone 2 cycles of chemotherapy. While on chemotherapy, uh, she developed this fistula. So what do you think? What is the information you can gather from that? Because we don't know what is happening inside the abdomen. You need to do a CT scan or PET scan the way they are doing it there. Otherwise, we don't know what is happening inside. But outside the body, we can see there's a fistula now. So can we take this as disease progression? What do you think? Then the patient told me that I think the disease is getting worse. So I didn't tell it. I allow the family and the patient to understand that and tell me. So that is the best way to communicate. Rather than you telling things, you get the answer from the patient and the relatives. Then I told, what did the primary oncologist who has started chemo told you about the chemo? Then I need more information. What was the purpose? Then they told, okay, doctor told there are 3 things. One is there can be miracles. Then the husband told, but we know that miracle won't happen. Miracle means cure, right? It won't happen. So they know that is not going to happen. The second thing is, while on chemo, disease can control to an extent that she will control the disease and live. Opinion is, at the moment disease is progressing, but you can decide. Then they said we need to take her to India for the chemotherapy. What shall we do? Is it dangerous? Then I said, at any moment anything can happen to this patient, your mom, your husband, anything can happen. Even during the stay in this hospital, she might even die due to a massive bleeding, due to another septic event. She might get a septic shock. There can be peritonitis, right? She might die due to that. So, but even during the flight back to India, she might die. So what do you think? Then they said the doctor is expecting us there. Then I gave them an option. Before you go there, you can tell the doctor about the patient's condition, right? Then they asked me whether you can give a letter. And then I said yes. Now these are the things we should do. Help the family to come to a conclusion, right? These are small things, but sometimes we don't do. I have given a summary about the patient. I have summarized the patient condition. And I have mentioned there, my opinion is patient is having progressive disease in spite of getting palliative chemotherapy. And I feel that the chemotherapy is not giving any benefit. But I don't know what is happening inside the tummy, inside the abdominal cavity. So sometimes they might need to do imaging studies to decide it. But for me, clinically, this is progression. So, so they sent the letter, and her daughter wanted to go to India before the mother and discuss with the consultant. They went, and then they decide the Indian doctor wanted to take the patient there for the further treatment. So the family requested me, can you keep the patient until we take her to India, and can you optimize her? And I said, okay, whatever the symptoms she is getting, I can manage. Actually, she didn't have much pain. Only problem is time to time she is getting high output. So we are giving codeine on and off syrup, and we are replacing the electrolytes. But we didn't have to give blood again because bleeding was stopped with tranexamic acid and hemoglobin was stable. And she didn't had any, further progression of fatigue. And in fact, she became, her fatigue became less and less. And she is getting to understand what is happening also. So one day she told me, doctor, I know what you are telling. I know this is beyond cure, and I know whatever the chemo is giving me is not going to give any benefit, but we'll go and see what they are telling. And I'm the person who is going to decide at the end whether I'm going to get chemo or not. If I see chemo is not going to give any benefit, I'm going to stop it, and I'll continue the symptomatic management. So that was what she told me, and they were very happy the way that the approach which we have done, and they were requesting several documents. Now this is something what what we are talking about in palliative care, transferring of care. So now we need to prepare certain documents. Now they are asking various things, fitness for traveling. So all these things we need to do, right? Otherwise, sometimes we tend to avoid those things, but these are very important. We are supporting the family and the patient. So I told about one patient who had traveled like this, what has happened to that patient. So I'm giving I'm sharing some experience from my side for them to understand even that patient might die even during the stay in overseas, and what are the difficulties that they can encounter. So I told about one patient who had multiple lung mets, gone to Singapore, and ultimately end up in a ventilator, right? And when they wanted to bring the patient to Sri Lanka, they have to hire a air ambulance, so huge amount of cost. And returning to Sri Lanka in the airport, the patient has passed away. So I gave those information for them to think the risk they are taking, but I can't tell them not to go. That is their decision. So you need to respect their decision, right? So on 9th, actually, they left. They were discharged from the hospital on 8th, and 9th they fly to India. So I don't know what has happened after that. So what are the learning points from this small case? I mean, this is not a very complicated, big clinical situation. This is a very small, short case. What are the learning points from this? Can anyone tell me one learning point from here? Palliative care purposes, at least.
Good communication with the family.
Communication, very, very important. Communication is very, very important, right? I will give you another example. Again, last week, another patient came to us, lady with a distal colon cancer with impending obstruction. And the CT or imaging studies revealed that she is having multiple liver mets. So, but the relatives told me that patient is not accepting that she is having a disease. Now this is called denial, right? This is called denial. She doesn't believe that she is having a cancer. So then I have to explain it to her. So I asked her, why did you go to hospital at the beginning? She said, I had bleeding per rectum. When I was passing stools, I had bleeding. Then I asked, okay, so why did you go to hospital with bleeding? මම දොස්තර මහත්තයා මම හිතුවා මේක හෙමොරොයිඩ්ස් හින්දා වෙන්න ඇති. ඒක හින්දා තමයි මම ස්පිරිතාලට ගියේ. හරි? Okay. So if it is hemorrhoid, why did you go to hospital? Now this discussion has to be little bit firm, straightforward, because we are dealing with a denial, right? Then she said, if it is hemorrhoids, I need to confirm whether this is hemorrhoid. මට මේක hemorrhoids කියලා බලා ගන්න ඕනේ. If it is hemorrhoids, I need to get treatment. That's why I went. Okay. So what did the doctors do? What did the doctors do? They put a camera. Then I asked what they have told after putting the camera testing. After doing that, that's colonoscopy they have done. They told me that there was a lump. There was a tumor in the colon. මහ බඩවැලේ ගෙඩියක් තියෙනවා කියලා කිව්වා. Right. Okay. What else they did? ඒගොල්ලෝ එකෙන් කෑල්ලක් ගත්තා. They have done a biopsy. Okay. Have you got the report? Yes, they have got the report. Do you know the report? No, I don't know yet. Have they done anything else? ඒගොල්ලෝ CT එකක් පුත් කරා, CT scan එක. Have they told anything about it? මම දන්නේ ඒක ගැන. Right. ඔයා මේක ගැන දැනගන්න කැමතිද? She was not very positive, but she was telling, come on, කියන්න doctor. But I have some doubts looking at her face, the facial appearance. There were two, her daughter and the daughter-in-law was there. So then I asked her, are you sure that you want to know? Come on, I think කියන්න doctor ඉතින් මොනවා වුණත් මම නෙමෙයිනේ තීරණය කරන්නේ දොස්තර මහතුරුනේ කරන දේවල් තීරණය කරන්නේ. No, I told no. Doctors won't decide what to do. We explain what are the possible treatments and you have to decide what to do. Then she told, no, my children will decide. Then I asked, she was trying to avoid the conversation by telling various things. Then I asked, are you afraid of knowing the truth? මේක මේ ගෙඩියක් තියෙන්නේ මේක ටිකක් බරපතල එකක් මේක ගැන විස්තර දැනගන්න ඔයා බයයි වගේ. Then suddenly she dropped herself. The mood was dropped. Then she started to cry. So do you think that impression is good or bad? Crying in front of me, is it good or bad?
Good.
It's good.
That is good. Why? So her denial has now getting, that denial phase is now breaking. Now she is trying to understand what is, she knows now there is something dangerous, right? Then I told, ඔයා බයද මේක දැනගන්න? මේක මං කිව්වනේ ටිකක් බරපතල එකක් කියලා. ඔයා බයද මේක ගැන දැනගන්න? අනේ ඔව් ડોක්ටර් මං බයයි. Then with whom shall I discuss with this? Is it okay with your daughter and daughter-in-law? Okay. ඒගොල්ලොත් එක්ක කතා කරන්න. කතා කරලා කොහොමත් ඒගොල්ලෝ තමයි තීරණය කරන්නේ. ඒකින්ද මේගොල්ලොත් එක්ක කතා කරන්න. So I have explained them the disease has spread to the liver. So patient is now outside. So I was discussing with the relatives. But at one point we have to discuss this with the patient. Usually the experience is after some time patient will ask many things. After knowing and after getting adapting to the situation, they will ask. Then we have to tell whatever they need. Right? This is again communication, right? So likewise, the communication is important. Now here in this case, I gathered some information before I go to the patient. I knew that there is a conflict. Then I have to be very careful in communicating with the family and the patient, right? So anything else? We go back from the beginning. Anything else?
Symptomatic management with proper information to the family.
Yeah, giving proper information with their consent. I mean, you may be knowing 100 things about the patient, right? But if patient or the family doesn't want to know them, no point telling them, because they will not absorb anything. So first of all, you need to know what they really need to know. So you can ask them, well, now you are getting treatment from India, okay, so what do you want from me, right? So first you need to address them, then you can see whether you can give some additional information to them, right? So when the relationship is building up, you can give more information to them, right? So now, so better not to have any conflicts. That is a very important thing. So communication, allowing them to, there are certain conditions. I think you might have had a lot of lectures, theory about good communication. So this is the exact practical situation which we are doing. So there are certain things to be fulfilled. There are many things. Somebody must have done the communication lecture with you. So you can go through it. Okay, so right. So, and small, using very simple methods to correct the things. Using very simple methods to correct things like putting a colostomy bag for the fistula. Those things are coming with the practical experience. And I think the swab should have taken from, they must have taken from the fecal matter. That's why it's coliform positive, but definitely there are some soft tissue infection. So we gave the trial. Always in palliative care, you can use trials to control the symptoms. And if trial is getting, positive results, you can continue it. Otherwise, you can stop it, right? And even blood transfusions. And I tried to discuss with them about DNR, but they accepted it. I explained about not giving cardiac massage, not giving ICU care, not connecting to the ventilator, the benefits and the risks. All these things I have discussed with them, but they didn't sign the form. But you may have to discuss again and again. So at one point, they will agree with me if they come again, not to do resuscitation. So when you are discussing with DNR, do not resuscitate. You have to discuss in a very sensitive way. Not doing this thing, that thing is actually for not to do any harm to the patient, but to do some good to the patient. So that is very important, right? Then blood transfusion at the appropriate time, and helping the patient and relatives when they are requesting. So all these things you have to do, preparing letters, making phone calls. So those are very important. Even actually they were asking whether I can talk to their primary consultant, and I said okay, they can make a WhatsApp call or whatever the way. I will share my information with them, but he didn't call me. But if he has called me, I would have answered to the call, right? So those are important things. So until their request, I have helped the patient. So they were very happy. And they gave the positive results. Positive answer. They might come back. I don't know what is happening now. After coming, I will know what they have done. But anyway, I put my opinion to the discharge summary, mentioning that patient is definitely on end of life care. She may not live more than 1 year. So good palliative care is needed for this patient. That I have documented. So the clinician there can see it. So I hope they will not start chemo, but I don't know what they will do. So any questions you need to ask from this case or anything else? because early identification of the problems is very important. When she get fatigued, we identify the problem quickly, assess it, and we give the treatment. Whenever there is a fistula, we identify it quickly and we attend to that quickly. And complications, we identify it quickly, attend to that quickly, settle them, and patient was comfortable with that. So at the end of the day, the quality of life. So we maintain that. Okay. Any questions you need to ask? Okay. Right then, I think time is okay, no? 12:15 actually. Any questions?
What are the challenges in providing palliative care? What are the challenges?
Okay, there can be there are a lot of challenges. One thing is actually the first thing is if we are not confident enough to handle a clinical situation. Now, for example, suppose I'm communicating with the patient, right? And if I can't continue the communication, that will be a big challenge. So usually in the developed countries, what they do is they couple the clinicians. I mean, one clinician and nurse specialist will attend to the this sort of communication. And if the clinician failed to continue the communication, the other nurse specialist will help. I have seen it in UK when a respiratory consultant breaking a bad news to a patient, at one point the consultant was stuck, and immediately, without hesitation, the nurse specialist start to talk. I mean, that support should be there. So what I see in Sri Lanka is we don't expect that type of teamwork. We are not ready to accept that type of teamwork. That is very bad on us. So first thing is we should learn from the Western countries. There are certain things we have to learn. There are certain things we should reject. So the thing is that nurse specialist, she's having a degree and she know how to communicate, and she was an expert in her field, so she could actually help. So in our situation, I think we are a little different. I don't need to tell you because our resource personnel are less. For example, we don't have nurse specialists to help us. We have nurses, we are expecting everything from them, but when it comes to specialization, very reluctant, our system. But now we are breaking those barriers and we are trying to improve, but we are not at that level. The second thing, now the ability, skills. Actually, the resources, we don't need much. We don't need sophisticated things for palliative care. Very limited resources are enough. But we need certain medications, for example, morphine, fentanyl patches, because when we don't have access to them, that will be a big problem. But the skills are the most important thing, and more than that, the attitude of good attitudes of helping others. It's actually empathical attitude that is very important. So if you don't really need to help someone, even though you have skills, even though you have more expensive facilities, the staff, you will not help them. So attitude first. So you can see, I mean, that attitude will come from role models. That means the people who deliver when we take the area of palliative care. So you need to see how the palliative care role models, the key people, key resource persons are working. So we have a lot of, that sort of people in India, in Singapore, various other places. I'm not telling we don't have those people, we have, but we need to learn from them how they have started, why they are doing that, and how they overcome the difficulties. So those things, for example, I should mention the name of Professor Santiago. Actually, she has passed away due to a pancreatic cancer, but she is the one who changed a lot of palliative care attitudes in Sri Lanka, right? And still, I think some of the clinicians think we don't need to tell the truth to the patient. Some clinicians, they want to tell, but they don't have the ability to tell, right? But those things were, told by those clinicians. And even India, there are a lot of palliative care specialists who came to Sri Lanka, and we can learn from them. So likewise, the attitude is very important. So when you have the attitude, then build up the skills. Skills also need to be built up parallelly. When you build up the skills, then try to find out the resources. You can do parallelly all these things. Now we know when we want to relieve one of the patient's pain, if you don't have morphine, you feel frustrated. But you can heal the pain without giving morphine even. Sometimes you can heal the pain with complementary therapies, right? There are some patients, even the pain didn't controlled with morphine, but with complementary therapy, like listening to music, aromatherapy, massaging, meditation. Those things you can use to control symptoms. We have done it. So that means even with less resources, you can try and see. And you go to a patient and just talk to them nicely, and half of the symptoms will relieve. They are telling it. So make a difference. Challenges are there, but don't consider that as a challenge. Start it, you can do it.